Just
It's
continue.
recording.
Yeah, sorry. So starting with the gross anatomy, I think you learned this in anatomy your first year. There's so the stomach is divided into different parts. So before the stomach exists, there's this tube called the esophagus, and then after the stomach, there's the duodenum. The stomach has different parts. The part that the esophagus enters the stomach is called the cardia. Up here we have the fundus, we have the body here, and then we have the pyloric antrum here, and then there's a pyloric canal here. So there's this greater curvature here, and then there's also the lesser curvature here. So going to the blood supply of the stomach, the celiac trunk, after it penetrates and comes into after the abdomen, the aorta comes, it gives a branch. It gives the celiac trunk, which is consisting of three main branches. There's the splenic artery, there's the left gastric artery, and then there's the common hepatic artery. Okay, so literally, this left gastric supplies the lesser curvature here, just here where my cursor is. And then there's the splenic artery, which gives branches. There's these short gastric arteries, and then the left epiploic artery. This one, the right gastroepiploic, comes from the right duodenal artery, which is straight from the common hepatic artery. So it will, together with the left gastroepiploic artery, they will supply the greater curvature. Okay, so it will help us in some conditions, maybe the PUDs and everything. Going to the next, we have the physiology here. I've written here, what do you remember about your normal physiology of the stomach? So literally, most probably what you remember is that there are some cells that are producing some hormones and different proteins just to maintain the normal physiology of the stomach, right? So there's the parietal cell, there's the chief cells, there's the G cell. I think those ones are the most important ones according to this lecture today. Okay, according to the parietal cell, it helps us in producing the hydrochloric acid that is very much needed here during the absorption and in even nitrogen. It also helps with immunity. We have the G cells here that produces gastrin. Gastrin helps us in stimulation of the parietal cells so as to produce the hydrochloric acid. Parietal cells also produce the intrinsic factor, which helps us in absorption of vitamin B12, as you know. Most probably you learned that one in your hematology classes. Okay, going to the congenital anomaly. I specifically wanted this one because I think this is the one that is associated with the stomach rather than the abdominal wall. Okay, so this one is a pyloric stenosis. What happens here is that there's a congenital hypertrophy of the pyloric smooth muscles. Just here, we say this is the pyloric canal. Okay, there's the antrum here, and then there's the canal here. So this one, there's a hypertrophy, okay, of the pyloric smooth muscles. So the food contents and everything won't exit because there's this stenosis. This thing will cause stenosis. It will contract, and it won't be easy for food to move or to travel from this part of the GI to the other part. Okay, so literally, how do okay, the epidemiology, you'll see this mostly in male in charge infants. Also, 30% are seen in the firstborns. Okay, so it presents 2 weeks after birth. you won't see it literally. You won't see these signs like exactly when the baby is born. Okay, so how does this present? It presents with non-bilious vomit, which is projectile. Why non-bilious? Non-bilious because, as you remember, there's in a toddler, the pancreatic ducts and everything that come up from here, this part, gallbladder, nini, nini. That's why, the bile is being introduced into the GI system. I mean, like into the small intestines. So now that the food is here, and then like there's a contraction here that doesn't allow the food to mix with that bile, it will be non-bilious. Okay. What do you see? Like on inspection, you will see visible peristalsis. On palpation, you will see an olive-like mass in the abdomen. I wish I had a better picture to show you to you. That's it. Okay, let me go to the gastric disorders. The terms I want you guys to familiarize yourself with. These terms: there's gastritis, gastropathy, there's erosion, and then there's an ulcer. Okay, what is gastritis? That's what you might ask yourself. Gastritis is a histological diagnosis. Why histological? Because on histology you'll be seeing inflammatory cells. Okay, so gastropathy. Gastropathy. Actually, the histology is what differentiates the gastritis from gastropathy. Okay, on histology, gastritis you won't see any inflammatory cell, be it the neutrophils, be it the lymphocytes. Okay, so what's gastropathy? This one is used, this term is used when the hereditary and the degeneration are present, but then there's no inflammatory cells. Okay, so I'll move to the erosion. Erosion, a loss, okay, a loss of superficial epithelium. So the superficial epithelium. Is there anyone who remembers the normal histology of the stomach? What is the epithelium found on the stomach? Anyone? You can just unmute and then you just answer. Anyone? Okay. Can you guys hear me? Hello. Hopefully I'm
We
not
can hear
muted.
you.
Okay, that's better. Okay, let me just put it then. Seems like no one wants to answer. Okay, erosion. I said there's loss of superficial epithelium. Now this one is a small defect in the mucosa, but then it is limited to the lamina propria. Okay? Does not penetrate the muscular mucosa. Because you remember, like there are different, like what is this called? Different layers. Okay, going from the epithelium, and then when the lamina propria, going to the muscularis, and then evo to kishuka. Get me? So this one, utaipata tuko superficial epithelium, and then it's limited to lamina propria. It doesn't proceed to the muscularis propria. I mean mucosa. The ulcer now, okay? This one now goes deep. It might even perforate the whole thing. Now, it might perforate the whole thing. Okay, let's come to gastritis now. So what is gastritis? As I explained before, gastritis is the inflammation of the gastric mucosa caused by an imbalance between the mucosal defenses and the acidic environment. The acidic environment, as I explained before, the hydrochloric acid. The mucosal defenses. Which are the mucosal defenses? Is there anyone who can answer this? Just normal physiology? Hello? Okay, I'll proceed then. The mucosal defenses, you'd find something like the mucosa, you'd find something like the bicarbonates, the blood supply. Okay, those are the mucosal defenses that are in the stomach. Yeah, thank you. Thank you, Joy. I see your answer now. Acute gastritis. What's the definition of acute gastritis? So acute gastritis, the term is being used. Okay, the term acute gastritis is used. Okay, well, I said before, you'd use, yeah, prostaglandins spear there. Prostaglandins. I'm coming to that. Thank you. So acute gastritis is atomica. Okay, let me just start with the gastritis thing. I said gastritis thing, inflammation of the gastric mucosa, but then usually diagnosed by histology. And yeah, so on acute, you'd find neutrophils. Just from the normal immunology, on chronic, you'll find lymphocytes. On acute, um, you'd find neutrophils. Okay, the etiology and the causes, things like NSAIDs, chemotherapy, alcohol consumption, stress-induced, and then reduced protective factors. Okay, how does NSAIDs affect? How does NSAIDs bring that mechanism of causing acute gastritis? Anyone, please? Anyone? You can just type it in the chat. I can see it now. Yeah, it inhibits the formation of cyclooxygenase. Yeah, cyclooxygenase does what? Yeah, cyclooxygenase produces prostaglandins. Which ones specifically? The E2 and the I2. Okay, those ones help in the protection of the gastric mucosa. Okay, so this one NSAIDs will interfere with cyclooxygenase, and then it leads to inhibition of prostaglandin formation. So the mucosa will be left defenseless. Chemotherapy? Anyone? Chemotherapy? How does chemotherapy work? Anyone? You can just type it in the group. Uh, yeah, there's a direct injury to the cells. Okay, that one exists. Plus, after the direct injury to the cells, there will be no replication. Okay, it might take time. Alcohol consumption, that one is the toxic, straight. It will damage the mucosa. Reduced protective factors, we've talked about the bicarbonate, we've talked about the blood supply, we've talked about the mucosa and the prostaglandins and everything. The mucosa is being produced by the fovea cells. Okay, so there are stress-related mucosal diseases. This one now happens to patients with severe trauma, extensive burns, and intracranial diseases. Okay, so stress ulcers, the patients will present with shock. Okay, unaweza pata patient pia kuna sepsis. Sepsis is an infection. There's also severe trauma. Okay, so um, from your knowledge, shock, there are so many types of shocks, right? So this one, it might cause a decreased mucosal perfusion. Okay, that one might lead to what? Anyone? You can just type it. Anyone, please? Hypovolemic. Hypovolemic, you'll see it in the Carlin ulcers. Yeah, but it still applies. I think it still applies. the fact that hypovolemic is a type of shock still applies here. Okay, going to the Carling ulcer. This one is associated with burns. In burns, most of the patients lose fluids. Okay, that one leads to hypotension. Most probably reduced blood volume and then hypotension. Okay, Cushing's ulcer. This one is seen in patients with increased intracranial pressure. Okay, so the logic is when you have increased intracranial pressure, there's increased vagal stimulation. This one leads to the release of acetylcholine. Acetylcholine inaenda kwa wapi? Parietal cells, leading to release of acid, hydrochloric acid. And then hydrochloric acid, we said, damage the mucosa. As simple as that. Going to the chronic inflammation of the gastric mucosa. It has two types. Okay, it has the autoimmune type, and then it has the chronic H. pylori type. Now this one is the most common type, usually. So let's start with the autoimmune gastritis. So this one is associated with immune-mediated loss of the parietal cells. Okay, the body produces antibodies against the parietal cell. We said the function of parietal cells is to produce intrinsic factor, to also produce hydrochloric acid. So when these antibodies are produced and then it leads to destruction of the parietal cells, meaning you'll have less hydrochloric acid, you'll have less or loss of intrinsic factors. Okay, and we said intrinsic factor helps us in the absorption of vitamin B12 in the small intestine. Correct? So how does the body respond to that? The body responds to that by increasing, increasing the release of gastrin. From where? The antral G cells. So literally the patients, you will see the patients will have, and because we say the G cells are found in the antral, okay? So patient will present with antral endocrine cell hyperplasia. We already said achlorhydria, reduced or less hydrochloric acid. There's also reduced serum pemsidogene 1 levels. Okay, so this one you'll see most commonly in female rather than male, and it's also associated with HLA-DR antigens. So hopefully you got the point. So the other type is the H. pylori gastritis, and we said this is the common type, and then it occurs in the antrum. Okay, so due to H. pylori induced acute or chronic inflammation, okay, because it can be acute or it can be chronic. Acute, I love like you just get to diagnose it early and then like you eradicate it, or it stays for long and then it becomes chronic. Okay, so the pathogenesis here is that, okay, what are the things that H. pylori uses during the, like when it wants to conquer like a certain part of the body? Okay, they're just here, actually. The flagella, there's the urease, there's the adhesins, and then there's a cytotoxic associated gene A, supposed to be gene A here. So the flagella, it uses the flagella for movements. Okay, urease. Now this one urease, you remember urease converts urea into ammonia. Okay, so now when ammonia is being produced, it raises the pH of the surroundings of that phenatoid H. pylori. So meaning like when it increases the protein, like this H. pylori uses this as a protective mechanism. Like it doesn't get to be known like it's here because the acid will kill the. Remember, acid is used for immunity. Yeah. So the acid height recognize that H. pylori is here. So the base, which is the ammonia that's being produced, will neutralize the acidity. Other since this one it helps cells to attach to the fovea cells, and then there's the cytotoxin associated genes. This is a toxin now. Okay, how does the patient present? The patients present with epigastric abdominal pain. What are the complications? There's increased risk of ulceration, something called peptic ulcer disease. Okay, there's also increased risk for adenocarcinoma and multiple lymphoma. Okay, how do you diagnose? Okay, you use serological, non-invasive serological tests for H. pylori antibodies. That's the first one. Urea breath test, okay, stool test, culture, and PCR. So I want someone to explain to me how this works. The urea breath. Anyone? Anyone? Okay. Just increasing your workload actually. You'll have to do it by yourself. Okay, the treatment. So when you treat the cause, which is H. pylori, using what? What do you use to treat H. pylori? Umefika wapi Famco? Hello? Anyone? You can just type it in the group.
Endocrine.
Okay, endocrine. Yeah, antibiotics. You can use antibiotics. But then like there's something called, yeah, bismuth, okay, PPI, correct. Most probably you guys have heard of something called the triple therapy. Correct, Khalid. Triple therapy iko na nini? Anyone? What does it consist? Anyone? Okay, a PPI is a must. Yeah, thank you guys. Correct. So we'll move to the next. Anyways, yeah, this one is a methylene blue staining of the gastric first. And then here you can see the H. pylori. Okay. I remember this one was tested in our pots last year. Oh, PUD. So PUD, we said PUD is peptic ulcer disease. Actually, it doesn't only apply to the gastric or the duodenum. Okay, yeah, there is quadruple therapy, but it is used when the triple therapy doesn't work. So that's where the bismuth comes in. So PUD, it doesn't only apply to the stomach or the duodenum. You can find it also in the esophagus, but it depends on where you read. Okay, so there are two main causes of PUD. First one is NSAIDs, and the other one is H. pylori. You must be wondering why H. pylori is so tough. So kuna zingine pia, something things like smoking, alcohol plus ZE. What is ZE? Anyone? What does ZE stand for? Yeah, correct. You guys are reading. Ah, so that is one of the causes here of PUD. Okay, but then there are two main types. There's the gastric and there's the duodenal. Let's start with the duodenal. The duodenal is the most common type. It's being caused by H. pylori. 95% of the duodenal PUD is caused by H. pylori. The other 5% is caused by Zollinger-Ellison syndrome. Okay, so what does Zollinger-Ellison syndrome do? What happens here in Zollinger-Ellison syndrome? Anyone? Yeah, there's a hypergastrinemia. Why? Why is there a hypergastrinemia? Or what is the logic behind this hypergastrinemia? Yes, there's gastrinoma. A gastrinoma is a tumor, a gastrin producing tumor. Okay. And then that gastrin produced goes to the parietal cell. The parietal cell is being stimulated to produce a lot of hydrochloric acid. Okay. So where do you find this? You will find it in the anterior duodenum, but you can also find it in the posterior duodenum. The posterior duodenum one is the one that has a lot of complications, and we will come to that. So clinical presentations, how does the patient present? You'll see the patient on a epigastric pain. This epigastric pain is being relieved by meals. So the logic here is that whenever this patient feels like they have the pain, they'll try to eat. Okay, they'll try to eat and to eat every time, like so that just to reduce the pain. But what is the end product? They'll gain weight. Okay, so going to the diagnostics, you'll get the biopsy that indicates biopsy will indicate actually hypertrophy of the Brunner's gland. Okay, so the complications of duodenal ulcer is perforation. Okay, this one will lead to the rupture of the gastroduodenal artery tulipitia huko juu. That's this why I brought the blood supply, anatomy, and everything. So how does that present later on? Acute pancreatitis. So, but then the good thing with this duodenal ulcer is that it doesn't proceed to cancer. That's the good bit of it. Plus, it's being relieved by meals. Next, let's go to the gastric. So the gastric ulcer, this one is caused by H. pylori and also NSAIDs. Okay. Plus, you can find gastric carcinoma causing this, the intestinal type. Okay. So it's less common compared to the duodenal ulcers. And then this one is located in the left sarcophagus of the antrum. Okay. The other one was located where? Anyone? The other one was in the duodenum. Just straight from the name, duodenal ulcer. Presentation, epigastric pain, BADO. Yeah, thank you, Joy. So this one now worsens with meals. Okay. So in real sense is that patients will try to avoid eating because they know that one will lead to pain. The end product is that the patient will lose weight. What is the complication? Complication that it leads to perforation. Okay. The perforation later on leads to the rupture of the rupture, leading to what? The bleeding from left gastric artery. Now this one will be an emergency case, and you'll have to intervene surgically. Actually, we go to the next. Yeah, actually, this is This is how PUD looks like. There'll be a bit of inflammation, but you see this one is now well demarcated, punched out. Okay. Going to the gastric adenocarcinoma. So this is the most common malignancy of the stomach. It comprises of the 90% of the gastric cancers actually. Okay. You see it in male, okay, than females actually. So male, not just like a normal male, but in the older age actually. And then it's mostly seen in Asian countries. So the etiology, we have exogenous factors. We also have endogenous factors. The exogenous factors might include H. pylori infection. So, and then the endogenous factors are things like gastric ulcers, partial gastrectomy, or a positive family history. Okay, so going to the clinical features, in the early stage, gastric adenocarcinoma is asymptomatic. You might see some things like loss of appetite or nausea, but then it's asymptomatic totally. Late stage, you'll find dysphagia. What is dysphagia anyway? Dysphagia, anyone? Anyone who can describe what dysphagia is? Anyways, haina pressure. Bado hamjakuja clinical years. Yeah, thank you, Syed Salma. Thank you. Okay. The patient will also present with abdominal pain. The patient will also present with early satiety. Okay. The patient will also present with vomiting. But then now, this is a carcinoma. Okay. And literally what you get with carcinomas or masses within the body, I mean, like if it's in the GI or it's in the RESP, like literally blood is being involved. Okay. So literally later on when the patient vomits, you might find hematemesis. Okay. Or that blood might get absorbed. Okay. And then the patient will present with melena. What's melena? Melena, anyone? Hello? Oh, sorry. The chat is already here. Blood in stool. Okay. It's not necessarily blood in stool. Blood in stool is called hematochezia or hematochezia, whatever it is. Dark stool, yeah, that's what applies. Okay. There's also hematochezia, which is blood in stool. There's also occult blood. Get to know the difference between these three things. Huwa zinakwanga zina confuse. Okay. Okay, in the late stage of gastric adenocarcinoma, it metastasizes and it can go to different parts of the body. Okay, but we'll come to that later. Acanthosis nigricans, what is that? Okay, this one now, you can just find this one. Mostly it presents in the armpits. Okay, presents in the armpits. But then like it's characterized by dark patches. I had a picture, I don't know why I didn't include it in the slides. But it's fine. You can just Google it and then you'll see it. Classically utaipata kwa patients with gastric adenocarcinoma. So there's something called Lauren classification that is used to classify gastric adenocarcinoma. Lauren Lauren classified this into two types, intestinal type and a diffuse type. Intestinal type is the most common. So where does intestinal type occur? It occurs in the nasal curvature. Just like what? A gastric ulcer. How does it appear? This is the appearance. Yeah. So how does it appear? It presents with a central ulcer, and then you will see these margins here. They are irregular, and then they are heaped up. Zinakuja juu. Okay, is that clear? This is a central ulcer. Okay, what are the risk factors? Nitrosamines in smoked meats. This is linked to cancer. Which cancer? The intestinal type of the gastric adenocarcinoma. Literally, this is mostly seen in places like Japan and huko mbalimbali. Type A blood group, okay? And the way we usually remember this one is by writing gastric CA. CA means cancer, it's a short form for cancer. But then that A plus this A, that's how I use it actually. Actually, that's how my teacher taught me. Um, he's our teacher, not our lecturer. The other teacher, Mr. Pathoma. So there's increased risk for autoimmune gastritis and then carcinoma. For patients with type A blood group, okay? Intestinal metaplasia, what causes this? Straight, H. pylori causes. Okay, let's go to the diffuse type. Okay, this one we said is the less common type. It's not associated with H. pylori plus isonitrosamines, gininin, okay? But then this one, histologically, okay, what we have here, you'll see an infiltrative growth pattern, okay? Literally, the thing is, whenever you find like so many nucleus coming close, like zimekuja pahali mingi sana, think of a malignancy, okay? So the thing is, uh, this one displays an infiltrative growth pattern composed of signet rings. Who knows how a signet ring looks like? Anyone? How does a signet ring look like? Okay. Now for a signet ring, let me show you an example. Something like this. Okay? You guys can see it. The nucleus is pushed towards the periphery. By what? Salma, what pushes the nucleus to the periphery? Yeah, mucin. Thank you. Mucin is what pushes the nucleus to the periphery. And it looks like a ring actually. Here in Ipet in your unavanga actually. That's how it looks like. That's why it's called signet ring. Okay. On gross, this is how it looks like. You'll see a thickening of the stomach wall. Okay. Caused by what? A plastic reaction. This one now stiffens the gastric wall, resulting in thickening of the stomach wall, giving a leather bottle appearance, something called lenitis plastica. I don't know why I wrote plastic. It's plastica. I'll correct it later. Okay, so before, when we were going through the signs and symptoms of um, gastric adenocarcinoma, we said it metastasizes. Where does it go to? It goes to the liver. It causes what? Hepatomegaly. And like anything associated with the liver, you can get ascites. Okay. How is there anyone who can explain this? the relationship between liver and ascites. Kwanza mnajua ascites ni nini? Anyone? Okay. Yeah. Fluid build up. Wapi? In the kidneys, in the lungs, in the heart. Where exactly? The abdomen. Great. So the thing is, like the liver cirrhosis thing doesn't start like the liver hepatocellular carcinoma just doesn't start like that out of nowhere. So like the first stage there's inflammation, it goes to cirrhosis. Cirrhosis might proceed to um so before the cirrhosis there's alcoholic liver in hizo vitu. Literally there's a reason why people say like your colleagues when they're going to drink they usually say like I'm going to challenge my liver today. There's a reason behind that. You can ask them why. Okay, so there's an imbalance between the proteins and everything. So this leads to accumulation of fluid in the abdomen. Okay. Okay, going to the lymph nodes. Literally this presents as left clavicular node. Okay. The left supraclavicular node will be enlarged. I don't know how to pronounce that one. In the preumbilical region, you'll find something called systematic Joseph nodule. Okay. Now this one is associated with the intestinal type. The ovarian masses, Crokenbach tumor. Okay, mshafika reproductive ama bado? Anyone? Mshafika reproductive? Okay, yeah, okay, haina shida. So you'll come across this one, Crokenbach tumors, ovarian masses, and they're quite, they're quite, when it comes to the spots, they usually test these things, these tumors. Just be aware of them. And I think that's the end of our session today. Most probably if there's another slide. Uh, that's the end of our lecture. Right. So thank you guys. And I think next immuno. Have a good day, guys. Inshallah. Hopefully you'll pass. Okay. But I just want you to do one thing. Before you go to a topic like a system, let's say the GI, let's say the reproductive, the renal, make sure you know your physiology. Okay. It helps a lot. You can't understand something that you don't know how it functions. Utateseka, my friend. So that's the logic. You go to physiology, you get to understand it well. The other trick I used to use is that I'll go watch lectures on Pathoma before I start reading the book. Okay. And one thing people usually say is that Robinson's is bulky. It's a question time. But the thing is, you can't just go and answer in a SAQs with the like the scanty information. Okay, so like it needs you to understand like you need to have like a better foundation on what you're going to answer. So what I advise you is that you go listen to a Patoma lecture. Don't write anything, just sit down, listen to the lecture, like give it total focus, okay, total concentration. It helps. And then later on, you can just go back to your Robbins textbook. Uh, you can just go through it, okay, recalling whatever you had in those lectures. There's also this book called exam prep. I'm sorry when I was advising you guys, mkianza third year, I never included it in that message. But I'm passing the information. So it's a bit late, I know, but you can still go through that. It presents the knowledge in question forms. Okay, it starts with the question, and then like it helps you know how in a project how you can handle this. The good thing is that you can't do IMED without pathology. You'll struggle again. So all this starts from physiology. You'll need physiology for your patho. Then later on, you'll need patho for your IMED. Okay. I think that's enough, and I wish you guys the best. See you on the other side next year. Have a good day. Abdurrahman, are you in the meeting?
Yes, I am.
Then you can begin.
Okay.
Need to go sleep. I haven't slept. Have a good day, yo.